The waiting room has 19 people in it. One of them is having a heart attack. You don't know which one. A triage nurse flags a 63-year-old man. He told the front desk he just doesn't feel right. Vitals are borderline, no chest pain, no shortness of breath, just a feeling. Behind you, a paramedic is bagging a 24-year-old found unresponsive in a parking lot. Track marks on both arms. You have about 90 seconds before brain damage becomes permanent. A psychiatric patient in room 7 has been waiting 9 hours for a bed that doesn't exist. Security just called. He's escalating. 3 ambulances are inbound. ETA 4 minutes. The board is full. Every bed is taken. 6 admitted patients should be upstairs, but the floors are full too. You are emergency medicine, the specialty that sees everyone, turns away no one, and never controls what comes through the door. That 63-year-old who just doesn't feel right. He's the one dying. You have about 20 minutes to figure that out. This is not the longest road in medicine. It might be the steepest. Level 1, the rotation. Third-year clinical rotations, surgery, internal medicine, pediatrics, psychiatry, and then the emergency department. The first shift is sensory overload, stretchers rolling past, a patient screaming behind a curtain, 3 conversations at once in the hallway. You've spent 2 years in lecture halls. Now a patient is in front of you, and you have 15 minutes, not 15 pages. The attending has a plan in 90 seconds. She's already on to the next room. There's always a next room. 4 hours in, the attending hands you a laceration tray, small cut on a forearm. Clean, straightforward. Your hands shake. The patient notices. He asks if this is your first time. You say no. It is your first time. The suture holds. It's not beautiful, but it holds. The attending checks it, nods, moves on. You stand there for a second longer than you should. That was real. That was a person's skin, and you closed it, and it held. The shift ends 10 hours later. You walk outside and the sun is in a different position. You forgot to eat. You forgot to check your phone. For 10 hours, nothing existed outside those walls. Some students hate the EM rotation. You can't stop thinking about it. Match day. 1 envelope. You matched into a 3-year emergency medicine residency. Your surgery friends have 5 to 7 years of training ahead. Cardiology, 6. Neurosurgery, 7. Yours is 3. That sounds like a gift. You'll find out what it costs. Level 2, the shift. First shift as a doctor, not a student, a doctor. The attending starts you on fast track. Sprains, lacerations, UTIs. 2 hours in, manageable. Then she pulls you out. Take the chest pain in room 12. Room 12 is a 58-year-old woman. Substernal pressure, started an hour ago. Could be a heart attack, could be acid reflux, could be a pulmonary embolism. The EKG prints, you stare at it. You've read 1,000 EKGs in textbooks. This one doesn't match any of them cleanly. Not obviously abnormal, not obviously normal. You present to the attending. She looks at the strip for 3 seconds and says, "Get cardiology on the phone, now." You were 30 seconds from reassuring the patient. That moment sits with you for weeks. You weren't wrong yet. You hadn't committed to a decision. But you felt how close you were, and the stakes weren't a test question. Later that week, a nurse pulls you aside, a patient in bed 4, mid-50s, dizziness, vitals stable. She says, "I don't like how he looks." She can't tell you why. You order the workup. Troponin comes back elevated, heart attack. Only symptom was dizziness. The most dangerous patient in the emergency department is not the one screaming. It's the one who looks fine. Night shifts start in intern year. The ED at 3 a.m. is a different hospital. The truly sick, strokes, heart attacks, asthma that worsened for hours before someone called. The overdoses, the psychiatric crises, the people who had nowhere else to go. So they chose the one door that stays open all night. By 5 a.m., you're past tired, in a place where fatigue stops registering and everything has a slight unreality to it. You drive home in morning sunlight. The world feels slow and bright and wrong, like jet lag from a country you never left. Something nobody told you about, EM. You don't carry patients. The shift ends and someone else takes over. You never find out what happened to the woman in room 12. In every other specialty, you follow patients for days, weeks, years. In emergency medicine, you stabilize disposition and move to the next room. You learn to live with that. Level 3. Running the board. You are the senior on shift. 2 interns report to you. The attending supervises, but you're running flow. Who gets seen, who gets discharged, who goes upstairs, who's been waiting too long. The board has 32 patients. Every name is a decision you haven't made yet. A trauma activation comes in. 20-year-old motorcycle collision, GCS 8, meaning he's barely conscious. You run it. 2 large bore IVs, type and cross for blood. Intubate. CT of the head and cervical spine. You call it out, and the team moves. The intern's hands are shaking around the IV catheter. Yours aren't. You notice the exact moment that happened. Not today, but at some point over the last 2 years, your hands stopped shaking in these rooms. You just can't remember when. Later that shift, an 81-year-old woman, brought by her daughter. Chief complaint? Weakness. Vitals normal, labs normal, head CT normal. The intern presents her, likely deconditioning, safe for discharge. You go see her yourself. Something doesn't sit right. She's slightly confused. Her daughter says she's always a little confused. You order a lactate, a blood marker, for tissue stress. Nobody had thought to check it. 4.2, normal, is under 2. CT abdomen, dead bowel. She goes to the OR within the hour. If you'd signed the discharge, she'd have gone home and probably died. This is the case you'll tell interns about for years. Traumas announce themselves. This one almost walked out the door looking fine. 8 of the 32 patients on the board are admitted, meaning they need inpatient beds. The beds don't exist. They're boarding in the ED, taking up space and nursing time. Some have been here since yesterday. Almost every emergency department in the country reports boarding patients for more than 24 hours. You're running an emergency department and a makeshift inpatient ward at the same time, and neither one has what it needs. Room 7. A 44-year-old man, intoxicated, suicidal ideation. He's been here for 11 hours. There is no psychiatric bed available, not in this hospital, not in the region. You can't discharge someone who told you he wants to die. He's angry. He's thrown a tray. Security is outside his door. He is also a human being who is suffering, and the system has no place for him. You are his doctor and his warden simultaneously. Neither role fits. This is what emergency medicine looks like when nobody is watching. The people in crisis that the rest of the healthcare system has no room for. 3 years. That's all of residency. Your neurosurgery friends have 4 more years. Cardiology has 3. You're done. Board exams in the fall, then someone hands you the keys. The specialty you're about to practice didn't exist 60 years ago. Before 1961, no one chose to work in an emergency room. ERs were staffed by moonlighters, rotating interns, semi-retired GPs. Then 5 physicians in Alexandria, Virginia, quit their private practices to staff an emergency department full-time. Their colleagues thought they were throwing their careers away. The American Board of Medical Specialties didn't recognize emergency medicine until 1979, 18 years after those 5 doctors decided this was real medicine. You are about to practice a specialty younger than most of your patients. Level 4, the attending. Nobody is coming to check your answer. In residency, every decision had a backstop. Now you are the backstop. Your name on the chart, your license on the line. Your first shift as an attending starts the way every shift will start for the rest of your career. You walk in and read the board. 15 names, 3 in the waiting room, 1 in the resus bay. You take a breath, pick up the first chart, and walk into a room. No call, no rounding, no clinic. Just the board, the patients, and the next room. For 10 hours straight. For the first few years, this feels like freedom. You see about 2 patients every hour, 15 minutes each. History, exam, orders, results, plan, next room, chest pain, fractures, strokes, overdoses, cardiac arrests. A man with a 3-week cough who showed up at 2 a.m. on a Tuesday. Since 1986, federal law has required every emergency department to screen and stabilize any patient who walks through the door. Insured or not, able to pay or not. Emergency physicians are 4% of all doctors. They provide 67% of all acute uninsured care. The board doesn't show which patients have insurance. It doesn't matter. You see them all. 2 a.m., a man is brought in by police. Found stumbling near a highway overpass, combative, smells like alcohol. The officers want medical clearance so they can take him to detox. The triage nurse puts him in a hallway bed. Just a drunk. You glance at the board and almost move past his name, then you walk over. He's not making eye contact. His speech isn't just slurred, it's asymmetric. The left side of his face isn't moving right. You order a CT of the head, subdural hematoma, bleeding inside his skull, probably from a fall that nobody saw. If he'd been left to sleep it off, he would have herniated by morning. The officers didn't know, the triage nurse didn't know. That's not a failure. It's the nature of the problem. Every intoxicated patient could be hiding something underneath. You can't scan all of them. You learn which ones to look at twice. That instinct is the thing residency couldn't fully teach you. It built the foundation. The attending years build the rest. Case by case, room by room, shift by shift. After 13 years of training and $215,000 in student debt, the median salary is $330,000, less than most surgical specialties. But nobody chooses EM for the paycheck. You chose it for the work, the speed, the variety, the fact that you will never have a boring shift for the rest of your career. The trade-off arrives quietly. 15 shifts a month means your days off fall on Tuesdays and Thursdays. You work Christmas. Your partner goes to dinner parties alone. And the nights are the real cost. You rotate between days and overnights, sometimes within the same week. Your body never adjusts. It just breaks and resets and breaks again. Blackout curtains, melatonin. You sleep from 9 a.m. to 4 p.m. and wake up to a day that's already over. Chronic circadian disruption is linked to heart disease, depression, and a shorter lifespan. This isn't burnout, it's physiology. The schedule is aging you. Level 5, the wall. The salary is the same, the shifts are the same, the patients are the same. You are not the same. Emergency medicine has the highest burnout rate of any specialty in the country. It has topped the list for 5 consecutive years. After a decade, the pattern recognition is automatic. You know the MI before the EKG prints, the sepsis before the lactate results. You're faster and calmer than you've ever been. And you're exhausted in a way that sleep doesn't fix. Tuesday night, you walk in for a 10-hour overnight. The board is the same board it always is. 30 names, 8 boarding, a waiting room that hasn't been under 10 in weeks. Your blood pressure has crept up. Your doctor brought up a statin at your last visit. You're 41. First patient of the shift, a 22-year-old psychotic episode, agitated, swinging at the nurses. You step in to help with the restraints, and he catches you across the jaw. Your lip splits. You clean it up in the staff bathroom, check the mirror, walk into the next room. There's no debrief. There's always a next room. That used to feel like momentum. Now it's the reason you never process anything. 3 hours later, a family in the quiet room. Their father came in with chest pain and coded. You ran it. He didn't make it. You sit with them and tell them. You know where to sit. You know the pacing. You know when to stop talking and let the silence do the work. Being good at this is a skill you never wanted. You step out and pick up the next chart. A cough. You see the cough. Meanwhile, the ground has been shifting under the whole specialty. Wall Street entered emergency medicine. Private equity firms bought staffing companies, cut physician hours, replaced doctors with cheaper providers. By 2023, the largest PE-backed EM company filed for bankruptcy. That same year, the residency match hit the lowest fill rate in EM history. The match recovered. The scar didn't. You start noticing who's leaving. A colleague switches to urgent care. 30% pay cut, but she says she sleeps now. Another goes into telemedicine. A third files for disability. Nobody retires from emergency medicine. They leave while they still can. The specialty doesn't lose its worst doctors to burnout. It loses its best. The fastest, the most experienced, the ones who made the Rhesus Bay feel calm. Those are the ones walking away. You haven't walked away yet, but you've thought about it on the drive home more than once. Level 6, the chief. You're off the floor, mostly. 5 to 8 clinical shifts a month, the rest is administration, staffing, budgets, quality metrics, throughput meetings with hospital leadership. You hire physicians, you watch them burn out at the rate you did. The hospital wants more shifts per doctor. You push back. Sometimes you win. A sentinel event review lands on your desk. A patient died in the waiting room. 4-hour wait, triaged appropriately, turned out to be a dissecting aorta. There were no beds. The boarding patients occupied every monitored space. Someone is going to ask whose fault it is. The answer is structural, but structural doesn't fit on an incident report. Someone's name goes on it. Today it's yours. Your department sees 200 to 300 patients a day. Every meeting is a version of the same request. More resources for a department that will never have enough. You still pick up overnight shifts, not because you have to, because the board looks different at 3 a.m. when you're the one reading it. Not as a manager, as a doctor. The new interns started in July. One of them is on tonight. You've been watching her. She's sharp, fast, a little too confident. She reminds you of yourself. She's presenting a patient, mid-40s, brought in by police, intoxicated, combative. She's already charting the medical clearance. You walk over, you look at the patient, you look at her. Go back in the room. Look at his face again. She does. She comes back and her expression has changed. She sees it now. You don't give her a lecture. You don't explain the 30 years of EM history or the founding principle or the federal law. You just tell her, never trust the story you're handed. Always go see for yourself. She writes it down. She'll understand later what you really meant. That every patient on the board is a question you haven't fully answered yet. That the quiet ones are the ones that keep you up at night. That the job is not the emergencies. The job is the decisions you make when nothing looks obviously wrong. It's 6:47 a.m. You're walking to your car after the overnight. The parking lot is cold and bright and quiet. The way the world always feels after 12 hours inside. Too slow. Too still. Inside, the day shift is reading the board. The intern is still there. She picked up a double. She's standing at the board now, scanning the names, trying to see what you see. She doesn't yet. She will.